Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for the second in a series of three CMEOCast podcasts titled Adding Tools to the Toolbox, New and Emerging Treatments for Psoriatic Arthritis. This is supported by an educational grant from Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC. I'm Alan Gabowski, Professor of Medicine at Weill Cornell Medicine, an attending rheumatologist and co-director of the Clinic for Inflammatory Arthritis at the Hospital for Special Surgery in New York, New York. I'm joined today by my dermatology colleague, Dr. April Armstrong. April is Professor of Dermatology and Associate Dean for Clinical Research at the Keck School of Medicine, University of Southern California, where she's also Director of Clinical Research Support the Southern California Clinical and Translational Science Institute, and Vice Chair and Director of Clinical Trials and Outcomes Research, and Director of the Psoriasis Program in the Department of Dermatology at the Keck School of Medicine, part of the University of Southern California in Los Angeles, California. Welcome, April.
Thank you, Alan. It's a pleasure to be here.
For our listeners, today's activity is eligible for American Board of Internal Medicine maintenance of certification credit, and also as a CME for MIPS improvement activity with the CMS. You can obtain CME maintenance of certification points by completing your post-test and evaluation at the conclusion of the activity. Be sure to fill in your ABIM ID number and date of birth on the evaluation so it can be submitted by CMEO to the ABIM. And over the next 90 days, actively work to incorporate improvements in your clinical practice from this presentation. In approximately 3 months, you'll receive a follow-up survey from CMEO, and CMEO will then send you confirmation of your participation to submit to CMS, attesting to your completion of a CME that you can submit for MIPS improvement activity credit. Our learning objective for this podcast is to apply key clinical efficacy and safety data for novel and emerging agents to treatment decisions in patients with psoriatic arthritis. April, let's start off with the principles of treatment for psoriatic arthritis. Indeed, the principles of treatment for any disease that impacts the musculoskeletal system.
Absolutely. So few principles of treatment I see my rheumatology colleagues as well as my dermatology colleagues really live by are: number one, obviously, to reduce pain in our patients' joints. Number two is think of ways in which we can really improve their quality of life. It's very important to prevent as much as possible the structural damage and its complications, because these structural damages, when progressive, can really lead to irreversible consequences and damage. In addition to that, it's important to note that oftentimes management by a multidisciplinary team can be very helpful, and we want to engage our patients as stakeholders in our treatment decision-making process. And then finally, it's important to identify comorbidities as they can impact our treatment choice. Now, when we look specifically at the multiple different factors that can influence our treatment decision, let's take a look at this funnel. As you can see, on the left-hand side of the funnel are what clinicians, what we bring to the table. And they are, for example, our clinical experience, our interpretation and knowledge of the guidelines by the professional societies, and our knowledge of the evidence, the new literature that is constantly updated. And then on the right side of the slide, what we see are these patient factors that are super important in terms of treatment decision process. And that is assessment of patients' disease severity, their comorbidities, discussion with them regarding their side effect concerns, not only their side effect concerns, but the likelihood of a patient who may experience certain side effects. And then finally, we want to take patient preferences into consideration as well. So as you can see, all these different multiple factors can play an important role in terms of the ultimate treatment decision. Now, let's talk about the various therapeutic classes that we have with regards to treating PSA. So first, starting with non-pharmacological therapies, and these can include physical and occupational therapy, recommending our patients to stop smoking, weight loss, and exercise. These can be very helpful in terms of adjunctive therapies that can help reduce the disease burden. Now, there are also symptomatic treatments, and primarily treatments that are directed at joint pain. And those can include nonsteroidal anti-inflammatory drugs, as well as local glucocorticoid steroid injections. Now, going on to talk about small molecules and DMARDs, the pharmacological therapies in the class of oral small molecules include methotrexate, sulfasalazine, cyclosporin, leflunomide, and apremilast. Not all of them are FDA approved. In fact, only apremilast is FDA approved for PSA at this time. Then we're going to talk about our classes of biologics, and they include TNF inhibitors, as you can see here, examples being etanercept, infliximab, adalimumab, golimumab, and certolizumab. We have our then one in class, that's IL-12/23 inhibitor, ustekinumab, also FDA approved for PSA. Then we also have IL-17 inhibitors, and in the US, FDA approved therapies include secukinumab and ixekizumab, both bind to and antagonize IL-17A. Then we also have antibodies against CTLA-4, and that is abatacept. Continuing on that, a newer class of medications in the treatment against PSA include JAK inhibitors and TYK2 inhibitors, and those are either approved or in late-stage development, and they include tofacitinib, upadacitinib, deucravacitinib. And then finally, we have our IL-23 inhibitors, such as guselkumab, risankizumab, and tildrakizumab. Some of them are being studied for PSA, and others, such as guselkumab, is approved for PSA. So as you can see, we really have this large toolbox of different medications to choose from for our PSA management.
Yeah, it's interesting to me as a rheumatologist that what we're seeing is that many of these drugs are being studied first in psoriasis. And then because patients with psoriasis have inflammatory joint disease, the studies are then being done in psoriatic arthritis. So we're often seeing the approval in psoriasis first, and then the carryover into psoriatic arthritis. That's not a uniform observation because there are certain agents that, as you know, are approved in psoriatic arthritis, but not psoriasis. But it seems to be that those agents are first studied in psoriasis and then move over into psoriatic arthritis. Now, April, in 2018, the American College of Rheumatology and the National Psoriasis Foundation got together and issued a guideline for the treatment of psoriatic arthritis because it is both a dermatologic and a rheumatologic disorder. I know you were involved with this process, so can you shed some light on it for our listeners and viewers?
Yes, I think this is a process where it's really a perfect example of how two specialties can work together for the good of our patients, and also evaluating data so that new agents and new targets and new treatments can really be synthesized in terms of guideline formation. So as you said, Alan, there's a collaboration between rheumatologists and dermatologists, and through ACR and the National Psoriasis Foundation. And the goal of this is primarily to really develop guidelines that can reduce oftentimes the large variation in care that we see in the real world. And these guidelines are helpful because it helps to synthesize evidence-based medicine up to that point, and then put them into guidances where the clinicians can look at and really think about how to apply them in an individualized way to their patients. Now, Alan, one thing is that in order to understand efficacy data well, we oftentimes need to understand the measures that help us really inform these results. So one of the key measures, as you can see, that are used, that we talk about all the time, is ACR 20, ACR 50, ACR 70, just this ACR scoring measure. Can you talk to me a little bit about how this measure was formed, most importantly, and what are the domains in this measure, so that as dermatologists and primary care physicians and other non-rheumatologists, we can have a good appreciation of what ACR measures?
Well, the ACR Responder Index was established to include a number of domains: a visual analog scale of pain, a patient global assessment, where the patient describes and determines their own assessment of their progress, a physician global assessment, the health assessment questionnaire, and finally, an objective metric of inflammation, either the SED rate or the CRP. These are all added up, and one looks for either an ACR 20, which is a 20% improvement in the number of tender and swollen joints, an ACR 50, a 50% improvement in the number of tender and swollen joints, or an ACR 70, which is a 70% improvement in the number of tender and swollen joints. So the domains are the same. We're just looking at a different quantitation of the measure of difference. And the other important thing is that you're looking at the measurement as a percent improvement. So if someone starts off with 10 tender and swollen joints and gets down to 8 tender and swollen joints, they have an ACR 20. And if someone starts out with 20 tender and swollen joints and gets down to 16 tender and swollen joints, they still have active disease, more active than the first patient, but they also have an ACR 20. So it's the percentage of improvement. Now, we can put all of the data for all of the agents you've mentioned on a slide side by side, but this is more for illustration and not for direct comparison. There have been very, very few head-to-head studies done, particularly in psoriatic arthritis. I also need to point out that the ACR responder index was initially done in rheumatoid arthritis and only then validated in psoriatic arthritis, as opposed to another metric, which I'll get to in a minute. But what you see in this slide, in this illustrative slide of comparative efficacy versus placebo, not comparative efficacy versus each other, is that all of the agents you've mentioned, whether it is the oral agents, the JAK inhibitors, the class of TNF inhibitors, the IL-12/23, the IL-17, the CTLA-4 Ig, or the IL-23 inhibitor that's been approved, have shown significant improvement in the ACR 20 as compared to placebo. And that's the only point of this slide. They all work, but we can't say from this slide which one works better. Now, I mentioned that the ACR responder index was defined in rheumatoid arthritis and then validated in psoriatic arthritis. In contrast, there is a very nice metric called the MDA, or minimal disease activity criteria, which was looked at specifically for psoriatic arthritis by my good friend Laura Coates and others, where they've looked at tender joint count, swollen joint count, the skin areas measured by the PASI or the body surface area, patient pain, patient global activity, both of those on a visual analog scale, the health assessment questionnaire, and finally, tender enthesial areas. A point count was assigned to each of those, and if the patient had 5 of those 7 domains, then they were thought to have an MDA, which was quantitated based on the number of points assigned. Now, April, the bar graph that I went over looked at a lot of different types of agents, but an agent that has come into particular interest as members of a class and also on its own are the agent representing the class of IL-23s, namely guselkumab. Take us through the data on this newest FDA agent, guselkumab.
Absolutely. So Alan, as you know, Discover-1 is a trial evaluating guselkumab in patients with active psoriatic arthritis who are biologic naive or had previously received TNF-alpha inhibitor treatment. And so what was found was that ACR 20 at week 24 was achieved by significantly greater proportions of patients who were in the guselkumab every 4-week group. In fact, that's nearly 60%. And in those who were randomized to guselkumab every 8-week group, 52% of them achieved ACR 20. This is compared to 22% in the placebo group. So what this amounts to is really a difference between the placebo group and the every 8-week guselkumab group, a difference of 30% difference in terms of achievement of ACR20. And I highlight the every 8-week group because that is the FDA approved dosing for guselkumab in PsA, which is the same as the FDA approved dosing that was used in psoriasis for its maintenance therapy. Now, let's take a look at other efficacy endpoints. So compared to the placebo, both guselkumab every 8 weeks and every 4 weeks group were also superior to placebo in terms of achievement of excellent efficacy in the skin, as well as level of functioning as measured by HAQ-DI and SF36. And now, if we take a look at the data here, dactylitis and enthesitis, we will understand a little bit more about the effects of guselkumab on those two aspects. Among patients who had dactylitis or enthesitis at baseline, regardless of whether the patient has had prior TNF treatment, nearly 60% of patients on guselkumab every 8 weeks achieved complete resolution of dactylitis, and 50% of them achieved complete resolution of enthesitis. Going on to look at a bit long-term data. Now we're going to take a look at 1-year data with guselkumab in psoriatic arthritis. And what we see here on the graph is the long-term efficacy of guselkumab on ACR20 over 1 year. And in these biologic-naive patients with PsA, with the most stringent and conservative analysis method of non-responder imputation for this 1-year data, what was found was that the proportion of patients on guselkumab every 8 weeks achieved ACR20. That proportion was 74% at 1 year. Now, this is important because this data shows that the ACR response, the ACR20 response after 24 weeks, which was a primary endpoint, actually continued to improve through 1 year. And this was used, again, this was calculated with the most stringent method of understanding the efficacy, long-term efficacy. So it's very important when we talk about efficacy, we also think about adverse events, the safety profile. And when we look at the guselkumab data, what was found is that few AEs resulted in study drug discontinuation. And there were minimal elevations in liver enzymes in the GUS or the placebo group. There were no serious infections, no IBD, and no malignancy signal. Now, Alan, now that we reviewed a bit about the guselkumab data, can you share the data for 2 of the emerging IL-23s?
Well, sure. Let's begin with tildrakizumab, which is being studied in active psoriatic arthritis. I think you can appreciate that at the doses studied and at the intervals that were used, tildrakizumab did better than placebo in this 24-week trial. The most frequent treatment emergent adverse events through week 24, which was the primary endpoint of the trial, were nasopharyngitis and diarrhea. There were no reports of candidiasis, inflammatory bowel disease, no major adverse cardiovascular events or malignancy. No patients discontinued treatment due to treatment emergent adverse events, which is important for a tolerability of the drug. No deaths were reported. Serious treatment emergent adverse events occurred in 2.2% of patients treated with tildrakizumab combined versus 2.5% of patients treated with placebo. The second agent is risankizumab, also looked at in active psoriatic arthritis. This was another double-blind, parallel design, dose-ranging phase 2 trial, which went out to 16 weeks. And you can appreciate the significant improvement in psoriatic arthritis ACR20 in the patients who were getting risankizumab versus placebo. Here, the most frequent treatment emergent adverse events through week 16 were infection pooled arms of 35.6% versus 28.6%. The most reported adverse event were upper respiratory tract infections, but there were no reports of tuberculosis. Adverse cardiac events only occurred in 1 of 143 patients, malignancy in 1 of 143 patients, Patient discontinuation due to adverse events was 2.8% versus 4.8%. No treatment-related deaths were reported. And serious treatment-emergent adverse events occurred in 2.8% of patients treated with risankizumab versus no patients in the group treated with placebo. This is a phase 2 study, more to come. Finally, just to round things out, let's look at upadacitinib, which was also looked at in psoriatic arthritis. This is not an IL-23. This is a JAK inhibitor. And here you can appreciate for upadacitinib that the percentage of patients achieving an ACR 20, an ACR 50, or an ACR 70 was higher in the groups taking upadacitinib, whether at 15 milligrams a day or 30 milligrams a day versus placebo. The primary endpoint of the study was, of course, the ACR 20 at week 12 for the population studied versus placebo. And you can appreciate the significance of upadacitinib at both doses versus placebo at that point in time. I always like to tell our colleagues that there's no such thing as a free lunch. And so every drug that we use needs to be factored into the construct of the risk-benefit relationship. And so to be equally fair to upadacitinib as to the other agents we've discussed, let me briefly go over the adverse events seen in the upadacitinib psoriatic arthritis study. And there you can see that there was a higher incidence of adverse events, serious adverse events leading to discontinuation, serious infection, herpes zoster, hepatic disorder, anemia, non-melanotic skin cancer, and CPK elevation at the 30 milligram dose than the 15 milligram dose. But AEs in the 15 milligram dose versus the placebo were pretty much the same. Serious AEs were higher in the 15 milligram upadacitinib group than the placebo group. AEs leading to discontinuation slightly higher, herpes slightly higher, anemia slightly higher, but nothing else of major significance in comparing upadacitinib at 15 milligrams versus placebo.
Great. Well, thank you, Alan, for that wonderful review of the two IL-23 inhibitors in their efficacy and safety for treating PSA, as well as the data for upadacitinib. Now, in podcast, when we talked about axial manifestations of psoriatic arthritis, can you talk a little bit about how axial involvement in PSA may impact our treatment choice?
Well, it may. As I indicated in our first podcast, there may be differences, but also similarities in axial psoriatic arthritis phenotype versus the idiopathic axial spondyloarthritis. And so people have been trying to tease this out in terms of response to therapy as well. This is a study of tofacitinib in patients with psoriatic arthritis of the axial variety. It is not approved for the treatment of axial spondyloarthritis, although it is approved for the treatment of psoriatic arthritis of all phenotypes. And here you see that when a very different measure, the ankylosing spondylitis ASAS score, was used to look at improvement in these patients treated with tofacitinib, you find significantly higher ASAS 20s and ASAS 40s, a 20% and a 40% improvement in these patients treated with tofacitinib than with placebo. So there may be differences in how patients respond as a function of their phenotype, as well as a function of the agent that we give them. Here is a study looking at guselkumab in patients with active psoriatic arthritis, but with imaging confirmed sacroiliitis. And again, you can appreciate that when looking at the ASDAS marker, the ankylosing spondylitis disease assessment score in this population of patients, you can appreciate that guselkumab did better than placebo, and the patients who were switched from placebo to guselkumab achieved good responses as well. And here we're looking at the number of patients who achieved a major improvement versus a clinically important improvement versus those who actually became inactive with their disease. At this point, April, I think we can summarize and bring our SMART goals into the picture. What we've tried to do is apply the principles of psoriatic arthritis treatment to optimize outcomes in our patients. We've acknowledged, as you did in the opening slides, that many factors contribute to the important decision-making, and more important, as we discussed back to back, the toolbox for psoriatic arthritis is expanding. And we need to be able to evaluate and apply clinical efficacy and safety data to our treatment decisions when faced with a patient with psoriatic arthritis. And that may include knowledge of their phenotype, knowledge of their comorbidities, knowledge of their disease activities, knowledge of their preference, and so on. This podcast is one of a three-part series. We hope that you'll take advantage of all of the episodes in the series. And these activities and a wide variety of other activities and resources on inflammatory disorders for both healthcare providers and patients are available on the CME Outfitters Psoriatic Arthritis Evaluation Education Hub. These activities and a wide variety of activities and resources on inflammatory disorders for both healthcare providers and patients are available on the CME Outfitters Psoriatic Arthritis Education Hub. To collect credit for today's activity, please click on the link to complete the post-test and evaluation online. Be sure to fill in your ABIM ID number and your date of birth on the evaluation so we can submit the credit to the ABIM, and participants can print their certificate or statement of credit immediately. Thank you, April, and to the listening and viewing audience for joining us today. As today, the treatment landscape is growing and will continue to grow. It's a very exciting time to be a rheumatologist and a dermatologist treating these patients. And hopefully, this gives us the ability to personalize treatment for our patients based on their needs and their preferences. Thank you.